Our next session is case-based discussion of hemostatic challenges in pregnancy, and I'm filling in for Atifa Chaudhry, who was injured, as I mentioned, and so this is a case of ours at Duke with a case of hers. This is a case of heparin resistance in pregnancy. We had a 20-year-old gravida 1 at 29 weeks with a large left iliofemoral DVT and new symptoms of PE after 3 days of full anticoagulation, who was sent to us from an outside hospital because she was not being successfully anticoagulated and she had this new PE. Her initial evaluation, she had a BMI of 27, unlike most of our patients. She had a swollen left lower extremity. She had a VQ scan that was significant for a high probability PE. Her fetal anatomy ultrasound showed the baby was head first at the 72nd percentile, so well grown, and a normal amniotic fluid volume. Her baseline labs were normal. On hospital day number 2 at the outside hospital, despite full anticoagulation, her anti-10A level was 0.25 when it should have been between 0.6 and 1. So her enoxaparin was increased to 100 milligrams twice a day, above her weight-based dosing. On hospital day number 3, her level was 0.4, so it was increased to 120 milligrams BID. And then on day 4, it was 0.36, so they increased her to 150 milligrams BID, which was basically 2 milligrams per kilogram twice a day. And then they sent her to us. And at our institution, she had an anti-10A level of 0.51, and our on-call OB team consulted hematology, and the fellow recommended starting bivalirudin. Now, for those of you who have more experience with cardiopulmonary bypass than we do in OB, bivalirudin has been used to manage the heparin resistance associated with cardiopulmonary bypass. Alternatives that have been used are agatroban, which is a small molecule and direct thrombin inhibitor, and antithrombin concentrate. Now, looking through the literature, there are no cases of bivalirudin being used in pregnancy, and argatroban, there are a few cases, but there are lots of cases of antithrombin concentrate. Interestingly, the junior faculty member who came in the next morning after receiving this consult, his husband was a pediatric hematologist, so they decided to call me. So what are other causes of heparin resistance? Well, besides a big clot, one is increased heparin clearance, which is a hallmark of pregnancy, period, but we don't see people requiring 2 milligrams per kilogram twice a day of enoxaparin. Increased heparin binding proteins, which is also true of pregnancy, but we still don't see that big of a dose being needed, and antithrombin deficiency. So here is what we thought we could use. Well, we're not going to give her unfractionated heparin if she's already showing a resistance to heparin, although somebody did mention that. Now, I should also mention that we see transplacental passage in agents that are smaller than 5,000 Daltons. So bivalirudin was small enough that it could have crossed the placenta, and we had no reports of its use in pregnancy. Argatroban is a smaller molecule, several reports of its use in pregnancy. Antithrombin, a very big molecule that does not cross the placenta, and there's hundreds of reports of its use in pregnancy. So What would you choose? Well, we chose antithrombin concentrate, which can normalize antithrombin levels for women with current thrombosis, in antithrombin deficient women with recurrent thromboses despite anticoagulation, and antithrombin deficient women with anticoagulation is desired but contraindicated, like delivery. So her antithrombin level was 44% of normal. On hospital day number 6, she got the plasma-derived antithrombin concentrate that's on the market. We used the dosing that is recommended with an initial dose described there, and then the maintenance doses, which were 60% of the loading doses every 24 hours to maintain antithrombin levels in the 80 to 120% range. And then on hospital day number 7, her antithrombin level after that infusion was 93%, and her anti-10A level was now up to 1.18. So her enoxaparin was reduced to 100 milligrams BID. She went home, and she received weekly infusions with antithrombin concentrate. This is where Dr. Gal Arapali took over. Gar, are you here? Okay. So we're missing a slide. But at 38 weeks gestation, she developed oligohydramnios, and it was thought that she should be delivered. She was brought into the hospital. She had was told to hold her enoxaparin dose for 12 hours. She started her antithrombin infusion, and then in another 12 hours, her induction was started. She had a normally grown baby through the vagina. She was restarted on her antithrombin concentrate, she received her antithrombin concentrate continually. She was restarted on her enoxaparin 12 hours postpartum, and at her 6-week visit, her antithrombin level was 43%, and she was given a diagnosis of antithrombin deficiency. So our next case is a 35-year-old gravida 1 at 21 weeks gestation with twins. Conceived after in vitro fertilization, and she had a large left iliofemoral DVT at 11 weeks. And while on enoxaparin 100 milligrams twice a day, she was subtherapeutic with an anti-10A level that was essentially undetectable. Well, now there you get the delivery of the other woman who was delivering while this other patient was pregnant, apparently. So the second woman has a CTPA that was negative for PE. Interestingly, they consulted maternal fetal medicine, who recommended warfarin. Not our first choice. But somebody noted that her antithrombin level was 24%, and they did some genotyping and found out that she was homozygous for an antithrombin variant. So just a word about warfarin. It too is a small molecule, and it's a potent teratogen. We don't have much data about the direct oral anticoagulants and outcomes of pregnancy. We don't think that they are as teratogenic as warfarin. They may cross the placenta, they may increase the risk of maternal and fetal bleeding, but they do not appear to be teratogenic to the degree that warfarin is. So the patient, the second patient had enoxaparin a milligram per kilogram twice a day in addition to the antithrombin levels. And they used the same formula we did to try to achieve levels of antithrombin, but found that during pregnancy, this is Dr. Chaudhry's case, the antithrombin doses that were required were much higher than predicted. Here you can see the antithrombin doses that they gave and when they gave them, and the patient ultimately received doses of 118 units per kilo, approximately 3 times per week. And despite the increasing in doses, though, that was what was required to maintain peaks and troughs in her antithrombin levels. Dr. Chaudhry put this nice slide together. This is what the patient received both at delivery and postpartum, and then ultimately at 2 weeks postpartum, the patient was transitioned to warfarin and maintained on warfarin thereafter. So in conclusion, antithrombin deficiency can present as heparin resistance, and antithrombin concentrate can be safely used in pregnancy. Thank you very much.